In our program here, though, engineering, we have a variety background. We have two faculty. They are doing the health human factor economics, and then one faculty particular involved in the diversity science. I think that's something very hot topic today. And then myself, I'm doing application research, and then we have another faculty doing the doing biomedical engineering type of wearable products. So those are the program we have. So my research is mostly focused on three things as the introductions. I'm focused on outpatient scheduling. I'm focused on the capacity planning. I'm focused on any patient flow, and then try to utilize the space as maximum as possible, so that we can treat more patients. And then definitely the outcome is more critical. They'll give you a little background. Mayo Clinic is we are profit organizations from the standpoint of treating patients. We are non-profit organization from the standpoint of taxing. So we don't have to pay profit. That's the good thing about a government treating us differently. Okay. So we make money that we probably don't pay taxes. And it's just stay in this one, so don't let Mayo people know about what I say. So the first project is outpatient. It's an outpatient chemotherapy template. This project started in 2017, and we implemented, and they're very successful. So has been implemented all over the Mayo Clinic. Mayo Clinic as a whole, we have a Rochester as our base. That's the biggest one. And then we stretch out to Midwest. We have a couple of facilities, Eau Claire and La Crosse in Wisconsin, state of Wisconsin. And we also have Alberta, Aortic, Red Wing, and also Owatonna as our bigger sites in Minnesota. But we have four of those smaller sites. So we have total like 17 different hospital systems. Some is critical access hospital. Like Rochester is the biggest one. We also have a facility down in Arizona and Florida. So this outpatient thing has been implemented into entire enterprise-wide. So using a similar type of approach. So what this project tried to do, when I started, you see this graphic right here. There's a chemo hub. So any clinic you go to, any outpatient clinic you go to, there's a chemo hub. Either it's two chemo hub or one chemo hub. So the problem is, why does the chemo hub happen? The chemo hub happens because the patient is waiting there. There's more patient than you can handle based on your capacity. So what we try to do when we see that, we want to cut it. We want to cut it looks like this. So we can leverage the beginning of the day and the end of the day data. So by doing this. So in order for us to control that, we have to create a scheduling template. The template is a fixed template. For example, you have from 8 o'clock to 9 o'clock, there's a 1 hour appointment slots. So that's your template. So when our patient requests, you can put it in the slots. So that's called template. So we try to achieve this. So in order to achieve this, since we're designing template, so a template is going to be fixed for a while. So we decided to use optimization approach. So optimization approach here, the purpose is trying to improve patient treatment quality and safety, and then reduce the nursing utilization. I'm gonna go into some of the detail there because it's gonna be very interesting. And then we pair out with something called Leveling algorithm. Leveling algorithm is gonna make the optimization model to come up with a solution that meets our requirement. So any questions so far? So optimization model, the objective is trying to minimize the nursing resource constraint. I'm going to get into the detail of what the nursing resource constraint do. And the decision variable is, in our system, we can schedule patient in a 15 minutes increment. So you don't have a 8:01, 8:04 stuff. So either 8 o'clock, 8:15, 8:30, that's a system limitation we have. So what we try to decide, the optimization decision variable to decide here is between 8 and 8:15, how many patients I should schedule. So that's a decision variable. So the constraint, definitely, I need to know for the chemotherapy, if you look at the table right here, different patient type. The patient type by the minutes, by the durations. You have a 60 minutes, patient coming for 60 minutes treatment. 2 hours, 3 hours, 4 hours, 5 hours, 6 hours. We have also 7 hours and 8 hours. Those patients are very rare. Those patients are mostly research patients because we have a clinical trial. So, but we also have 15 minutes and 30 minutes. 15 minutes and 30 minutes. I'm not listening here because that's constrained. I'm going to describe why I'm not listening here. 15 minutes and 30 minutes. 15 minutes make the majority of the appointments. So those things, I need to know how many 60 minutes I need in order for me to fix the template to run optimization. So, and then the next one, I need to know what's the staffing level. Remember the objective function, you try to minimize the nursing resource constraint. So remember, the chemotherapy is treated by nurse. So when patient needs a nurse needs to be there. So when nurse is not there, when patient needs you, then that's called variations. That's where our objective function comes from. That's called variations. So I need to know the staffing level. Staffing level means how many nurses I have between 8 and 9, how many nurses I have between 9 and 10, how many nurses I have between 10 and 11. This clinic started at 7 o'clock. So that's another complaint to our operations. The clinic started at 7 o'clock and at about 5 o'clock. So some nurses are 8 hours nurses. You know that from 7 to 5 is not 8 hours. So some nurses 10 hours nurses, some nurses 8 hours nurse. Sometimes some nurses only have time. So there's some challenge there to schedule the nursing staffing. Yes.
So is the nurse staffing that's input to this, or this is used to determine that?
Nursing resource is input into that. It's input that because I think the decision variable is not to determine what nurses staffing going to be.
You wouldn't want to change your mind about that or determine it?
Yeah, we can because that become 2 different objective functions. So that becomes the bilateral, over 2 level optimizations. And then we definitely have a specific space availability, and the 45 is the maximum at the time. Right now we expand it to 55. I'm going to describe why we expand it to 45 is the maximum, but that's where the leveling out visit is because we want to use the minimum chair as possible, still meet our requirement, our violation requirement, so that we have an opportunity for future growth. So resource constraint, that's the objective function. 3 nursing resource constraint. 1, patient nurse ratio has to be 2.1 to 1, 2.5 nurses, 2.5 patients to 1 nurse at any given time. Regardless the nurse is busy, regardless the patient is needed nurses or not. But if I have two patients, I need to have 1 nurse. If I have 3 patients, I might need 2 nurses. So that's 2.1 to 2.5 to 1 ratio. And the other constraint, the other nursing resource constraint is patient nurse has to be 1-to-1 ratio for the first 15 minutes and the last 15 minutes. The first 15 minutes nurses needed because they need to start the infusion. They need to start administer the infusion. And the last 15 minutes, they need to finish other patients. And then anything in between, any time in between, nurse and patient ratio has to be 1-to-1 as well. So think about 15 minutes appointment means the nurse has 100% with the patient. 30 minutes appointment, first 15 minutes and last 15 minutes, so nurse has to 100% with the patient. But for 1 hour, nurse only need to be there first 15 minutes, second 15 minutes, and the last 15 minutes. So you have nurse availability right in the middle of that. So they tell you it's pretty tight. It's not much you can fit in, but that's when we try to minimize nursing resource constraint. So there's 3 nursing resources we're discussing here. Any questions? So for optimization, we pair with leveling algorithms because we have a total of 45 chairs. So if I let optimization to run 45 chairs, it will come up with any solution to fit the 45 chairs. And that will have a minimum nursing resource variations. But they did not satisfy us because we want to have a chair that's open so that we can have a future growth. So the leveling algorithm, the first number of chair we put in there as a constraint is 35. So 35, see if they give us a solutions. So optimization may come up with no solution because the number of the 15 minutes, number of 30 minutes, number of 1 hour patients appointment slots. If we put in there, 35 may not come up with any solution. So we increase to 36. We increase to 37 until we reach the satisfied violation, which is the 35. The 35 is about 7%. 7% variation. So nurses are okay with 7% variations. So we continue to increase the number of jail until we reach that. So the 7% or 35. So that's what level up we do. Any questions? So when we did this project, we also provide then what are the future opportunities. So we run optimization for different patient mix distribution, various patient volume. So at the time when I did the project, they have about 160 patients a day. So right now they are reaching almost 200 patients a day. So that was 5 years ago, or more than 5 years, 2017, 6 years ago. So it's about 6 years ago. So we did this study, and then hopefully to allow them to grow until 5 years later they are run out of space. So that's when we actually have expansions in our unit from 45 chair unit to 55 chair. The expansion was happened to 2021. We started building it so we can use it for 2022. So any questions? So to your question, we actually talking about nurse. What would be your optimal staffing? And one of the paper I have, we have created 5 different scenarios about staffing. So given the staffing, we run optimization to see which staffing actually perform the best. So we did not try to optimize what's the optimal staff, but we just presented 5 different staffing to see what the nurse manager or nurses did they like it or not. But that's an opportunity for different staffing. What's the optimal staffing? So this is what I was talking about. We presented 150 patient appointment template, 160, 170, 180, 190, 200. So they give you a different mix of how many injections you have, how many disconnect you have, how many post-op draw you have, how many chemo patients. So within a chemo patient, we already described as a 30 minutes duration, 1 hour, 2 hours, 3 hours, 4 hours, until 6 hours, or even 8 hours. So those are the things we presented to them.
Good question.
Yes.
So what is the distribution of the hours among the patients? Like how many patients would need 2 hours, 3 hours, and so on?
We do have that. I don't have that on my slide. But I think we did give it the we use the average number. So we look at historical data, how many 15 minutes patient they normally treat on average, how many 30 minutes treat on average, and 1 hour on average. So we use the number to fit into the optimization model.
I see. So for different scenarios, like 150 patients to 200 patients, you use similar.
Exactly. So we use a similar percentage. Extrapolate. So I think that's an opportunity for some of the DRO work might be applied to, because this template, think about this template, we're going to fix the numbers. From day to day is going to be different. From month to month it's going to be different. From week to week it's going to be different. How can we accommodate that without a lot of overwriting? Overwriting means overbooking the patient into try to fit into it. So I'm going to describe the overbooking method we actually come up with. So because that template is fixed, so we have to accommodate patient 100% of the time, from day to day. And remember, in medical field, when we have a template set up, we put a template in for the next 3 months. You can't simply just have a dynamic template changing from day to day. How are you going to schedule patients? Schedule is not going to deal with that. They don't have the mindset say, okay, let me rerun this and tell me what the system going to do. And we use a system called Epic. Epic doesn't allow us to be that flexible anyway. So what we do, we come up with overall policy. What's the overall policy do? If you have a 3 hours open and you have a 1 hour patients, the question is, can you put this 1 hour patient into the 3 hour appointment slots? The answer is yes. Depends on how their experience, if the 3 hours will be filled in a short period of time. So you can take the 6 hours, break into 2-3 hours, or you can combine 1 hour and 2 hours become 3 hours. Breaking is not ideal because remember we have the when the nurses need to be for the 6 hour patient. When you break that, means you are requiring more nursing resource. So so when you, every time when it overwrites, you will increase the number of violations. So in order for them to have a whole picture, how the schedule look like, so we create something called tracker. This tracker they're using every day right now. So the tracker is going to be a real-time tracker. So they look at this, say, hey, today I'm going to overwrite the patients. Look at how has been scheduled. This line right here, the dotted line right here, that's how the template looks like. And those are the patient has been scheduled, and it has been scheduled, and then given the duration of the treatment, that's how many patients are going to be in the system. So they look at this. If they're going to schedule patients, definitely not anything in the middle. It has to be somewhere in the beginning of the day. So that's how they look at where they overwrite patients. So rather than show you what's the simulated result, I'm going to show you the real result. We actually implement this. We implement 2019 to 2017. The entire year of 2018, the result, without increasing any nursing resource, using exactly the same space, we are able to smooth the number of the chemo chair, about 40 chairs in a day. So 40 chair meaning the total have 45 chairs at a time, so they have 5 chairs open always. That's their growth opportunity for more patient access. And the chair utilization used to be about 75%. Now, because the new template dropped to 60%, meaning when a lot of patient was sitting there because they wait for nurses. Because we try to minimize the nursing violation, so we minimize when patient need a nurse, we minimize the chances the nurse not be able to attend patient. So we reduce the wait time. So basically that 75% drop to 60%, that's reducing wait time by 15%. And then this is a big one. We actually end up making $900,000 more for that year without increasing any resource. So that's the additional we made. I did not get any cut, but that's the big one for them. So that's why this has been attracted by other sites. So we implement Arizona, Florida, and any other health system site. And also there's a few organizations actually asked about this approach. They are actually trying to implement it as well.
So what do you mean by the dollar amount that you save? I mean, if you use the less amount of nurses, do you mean this
in addition? So we actually able to schedule 6% more patients.
Oh, okay. So because of increase of yeah.
Yes, increase the reduce the wait time. So we open up more chairs for patients to be able to fit in. So we increase the volume by 6% without increasing any cost. So that's where the $900,000 comes. So any questions? That's the first case study. Yes.
Can I ask a question about the leveling algorithm?
Leveling algorithm? Yes.
Yes, like you gradually add a cap
Yes.
and find a satisfying like confliction.
Yes.
So what if I just write a constraint the conflict and minimize the cap?
You can do that too. I think the reason we want to see how much, because at the time when I do this project though, think about this. Because I'm a researcher at Mayo Clinic. When I run the leveling algorithm, how do we come up with the 35 or 7%? That's something they feel like is reasonable. I have to show them, say, hey, this is 35 chair. This is how many violations gonna have. 36 shares, this is how many are gonna do. So they end up tell me, oh, I think we can live with that. So you can definitely program it to have that say, hey, I want it to be 7% and tell me how many chair I need. You can definitely program that way. But I think it serves a similar purpose. So remember when working in the practice, the real life industry, you have to be convincing. You cannot simply say, hey, that's what optimization tells me. Take it or leave it. You can't. You have to show them every step away so they can buy in. The reason implementation is successful, remember this implementation is not easy. We have to deal with the scheduler. We have to send a communication to all the provider. Never promise the patient say, hey, your chemo is going to be tomorrow at 10 o'clock. They cannot do that because we have a template. You need to let scheduler figure out what's the first opening for the patient. You cannot promise patient anymore. And you need to communicate with the patient, because patients tend to do what? Oh, can I get my chemo at 10 o'clock tomorrow? You can't dictate your time anymore. You have to let the program or the schedule decide when it's open. So so that way we can keep the integrity of this template. So that's a challenge we have. Any other questions?
Is that really given optimal solution theoretically?
Yes and no, because it changes all the time. It changes all the time because right now, we try to change this every 6 months. The one issue we have, because we know we won't be able to meet the patient demand, the different type of patient, 100% from day to day. So every 6 months we have to evaluate, is this template good enough? Because in Rochester, the scheduler able to use the template 70% of the time. So the other 30%, they have to overwrite the patient into it. So we try to increase the 70% to be higher, but unfortunately, now we only see it decline. So once the following the template becomes 60%, 50%, we have to go in and adjust the template. Because the patient population tend to be different. And then some of the newer drugs, it used to be 3 hours, and now it's just 5 hours. What are you going to do? You have to change the template to meet the demand. So there's a lot of moving parts there. Questions?
So if I understand that it's deterministic, but you're constantly updating it
Yes.
based on availability.
Yes.
Just want to add, like you just mentioned, there's like a dropping percentage of using the template. I'm kind of wondering what would be the potential cost for that? Is that because like maybe the distribution of the patient actually change over time, or are there any other possible costs?
So the population doesn't change all the time, because keep in mind, sometimes we have we just hire another positions. When we hire another position, means our volume will increase. So there's a lot of those uncertainty we cannot simply take into account. And then when we implement something, it will be open for the next 3 months. So if you hire another position in the middle of those 3 months, you'll suddenly your volume change, but your template doesn't change. So we always plan a catch up rather than proactively making changes. So that's something I think that's an opportunity there. I'm not quite sure I answered your question.
I'm wondering if you optimize this and say a nurse doesn't show up, you have these shocks, how does that increase
so
the
nurse didn't show up?
So suppose one of the staff doesn't show up
Okay.
that day.
Uh-huh.
So or the shocks happen, the supply shocks happen.
Right.
Then how does it change especially when you're completely optimized, then it's not very
Right.
it's very sensitive to these
Right.
things.
So that happens, especially during the pandemic.
Uh-huh.
So a lot of nurses like, oh, something I test positive, what I'm gonna do?
Yeah.
So we always have, so in Mayo Clinic now, the chemo nurse is very unique. They have to have a certain certificates just to administer chemotherapy. So when they are not able to perform, we have a hospital space. Hospital has nurses. So we have something called 4 nurses. We can always call in for them to come in. So that's the only way we can do. And most likely, we also have the nursing body. They have something called team lead. We have a nursing manager. Those are the chemo trainers. Sometimes we can, you don't have enough body. What do? You just jump in and start working with everybody else. So there's no right or wrong answer for that. You just need to find people who do it. All right. So the second project. Second project is called Proton being gatekeeper logic. This is slightly different than most of the application research kind of techniques we're looking into. So the goal is to reduce the patient wait time from the setup to bin. Basically, it's the setup time. We want to reduce the setup time. We want to reduce the patient lies on the table and bin is set up in a certain posture. It's very uncomfortable. So we want to make sure they don't move before the bin and shoot it into patient. So that's a proton beam. So you see the picture right here. This is called gantry. This entire room is called gantry. So this is treatment room. So this is move vertically 180 degree, and the table rotate horizontally 360 degree. So, and this thing right here is cold and very hot. The reason being, when we have patient lie on there, we don't want patient to move. Because every time you move, the beam cannot be shoot at you because we're treating tumor. We're not treating healthy organs. So we have to make sure you don't move. So the problem about why this become a problem? Because we only have one accelerator. Accelerator shoot out the beam. You can only shoot one beam at a time. And one accelerator shared by 4 different gantries. So in 4 different gantries, if I'm patients in the gantry 1, your patient is gantry 2, 3, and 4, just one at a time, no problem. But the problem is a patient has multiple treatments. So if I have 3 treatments, means I've been set up for the first treatment, the beam shoot it at me, finish the first dose, and then they have to reset on me to the different angle. Then I have to wait for the next beam because there's 3 other people in front of me gonna wait for the beam. So I'm gonna get to the next one. So you can see the potential waiting between gantries. And the problem is when you've been set up in the same position too long, I think the too long we define as 8 minutes. If you wait for a beam for 8 minutes, patient first of all tend to move, and second, because it's very uncomfortable positions, a lot of patients after their treatments, they tend to need to do a physical therapy. Why is 8 minutes shouldn't be an issue? You can remember the proton beam is one thing. When patients start this radiation oncology treatments, when they started, it always lasts 20 to 30 days consecutively, besides the weekend. So if you schedule patient on Monday, it's 20 days in the future, consecutively. So if you every beam you get, if you get 3 beams each time, 20 days, you get a total of 60 beams. 60 beams, each beam you wait for 5 minutes. That's 300 minutes waiting. 300 minutes. So that's a lot. So in order for us to reduce that, we try to come up with a logic. We are not tackling from the scheduling standpoint, but we are tackling, say, if a patient check-in, when should I take him to the room? So when patient check-in, what our guys are going to do, we're going to evaluate at when this patient check-in, what is the condition at the time among all my 4 entries. If I take this patient in after I set up, this patient gonna wait for a long time to get a beam, I might also take the patient in later. So that's the entire concept. That's called gatekeeper logic. So there are 2 things we're looking into here. One, if I'm getting a beam, I'm the next in line to get a beam, but my previous patient, the treatment is actually 10 minutes. In any case, I'm gonna wait for more than 8 minutes. So what do? I try not to pair out with that patient, right? In a different gantry, but pair out with the patient waiting for him. So that's why we need to minimize the overlap with a long field. So each beam you consider field. So field and beam starting from now is interchangeable. And then the other one is minimize the wait 3. But wait 3 means remember we have 4 different gantries. So if I finish my treatment, for my next treatment, I have to wait 3 other gantry to finish. So if it's 3 other gantry, one take 4 minutes, the other 2 also take 4 minutes, that total sums to 12 minutes. So I'm waiting for longer than 8 minutes. So I try to avoid that too. So I'm gonna show you how this thing looks like. The long treatment. If you look at this is all the white spot is waiting. All the very dark spot, that's where the treatment happened. And all those things are considered setup. So the initial setup always the longest one. So when this patient come in, doing the first setup, and then wait for the beam, finally receive the beam, and then set up again, wait for the beam, and treat again. Then this patient only have 2 treatments. Right? So if This is the patient I'm waiting for. There's no choice, I have to wait for a long time because that treatment is so long. So that's a long wait, long treatment. So you can also look at what happens if you wait for 2 patients. So this treatment right here, you waited for this one, you waited for this one to complete. So that's 2. So if these 2 sum together, it's still under our requirement 8 minutes, then we're okay, right? So wait 3. If you look at this treatment right here, you have to wait for this one to finish, wait for this one to finish, wait for this one to finish. Highly likely, those 3 sum together might exceed 8 minutes. So in this entire project, we focus on 2 things: long treatment and wait 3, because those are the highly likely gonna make patients wait more than 8 minutes. So what's the logic here? I'm going to just click through it. So the logic here is that patient, this patient coming first, that patient second, this patient second, and that patient third. This is the 4th patients, right? Because this is the beginning of the setup, and this patient coming after that 3 patients. So you can see this patients, this treatment right here, you have to wait for that one, So it could take longer. And this patient right here, you can wait for this one, so you wait for longer. So in order for us to do the gatekeeper, we decided to, since this patient is the last one coming, we're gonna push back. So it won't exist right here. So this patient will not wait for a long time. So this is the on-the-fly decision making. So when patient check-in, we need to check the status in every gantry, and we actually run simulations to simulate possible scenario. And then we make a decision on, this patient, if I take it into right now, it would make himself wait or make other people wait. Either way, we're gonna push this patient later so that we won't have a conflict with other gantry. So that's one way to do it. So when you push this patient back, the other 3 gantry patient has to come accordingly. Has to be pushed back accordingly. Because when you push back, you might make the other patients come in, has a conflict with them. So there's a lot of moving parts here. Any questions? Yes.
So how long does it take to set up a patient in a particular position?
How long it would take? The first one is always the longest one, because when patient come in, it depends on the type of patient. For adults, doesn't normally take too long. The maximum probably 5 to 10 minutes. But for kids, for pediatric patients, it always take longer. So pediatric patients tend to move. So what they do is we always knock them out. Because then they will move. So one of the things about the chemotherapy is the proton therapy is the physician, before patients start their treatment, the physician actually call patient in to do something called simulations. What the simulation gonna do, they're gonna study how they're gonna treat the patients. There's a tumor. What's the angle for the first day? What's the angle the second day? What's the angle the third day? And then you cannot shoot a beam, just kill the entire tumor right away. You have to cut a small slice every single day, so it's gone. So because how they tackle the tumor, you will have to rotate patient's position, rotate the gantry position in order to go into the angle, come into the patient's body. So in order for the patient to stay still, they often during a simulation, they come up with a fixture. The fixture will help patient to lie there. You can move. But even though it's a very uncomfortable position, because the fixture is going to force you to be there, to be in that position.
So is that setting up time included?
Yes, it's setting out including those.
And the downside, so you could make people wait have very low waiting time after being set up, but that would potentially cause situations where the beam is not used sometime.
It
just
could.
idled? Is that
It could.
that's the thing that pushes in the other direction or?
Yes, it could. So that's the one thing, we have to make a decision. Can I sacrifice some of the being idle time to accommodate patient not waiting too long? So there's always a trade-off. So we actually before we did this Gatekeeper logic, we come up with optimization model, simulation optimization model using sequential algorithm to fix this, because when the patient is treatment, each treatment is always short, very short. So you pair them up together, it's not going to be an issue. So we try the sequential algorithm. It reduced the average wait time, but it will still happen is the maximum wait time could still be exceeding 8 minutes. So we also do the same thing for wave 3. So I think that conceptually it's the same thing. So conceptually just where can we move patients, how we move patients so that we don't have a conflict. So I'm going to just describe the results. So we try different simulation results compared to original. We have a logic say if this long wait time, what do we determine? So if we're going to sum 2 treatments together, either it's 4 minutes, either 2 is 8 minutes, either 3 is 12 minutes. So what that interval should be. So we say that x is greater than 4, x greater than 3.5, and then plus the wait 3. So that's a different scenario we try to run here. So after we run in every scenario, what we're looking for is looking into a maximum. So you look at the maximum field weight. We don't want it to be greater than 8. So the best option is number 4. Number 4 right here is a logic with x greater than 3.5. Anytime we estimate the treatment to be each treatment to be 3.5 minutes, we're gonna run the algorithm to avoid the conflict. And then we're gonna put the wave 3 algorithm in there in every single time. So any patient coming, we actually implement this. Any patient coming, the scheduler is gonna run the algorithm right there, and then we'll inform the therapist in each gantry, should you take a patient now or should you take a patient later, and how much later? We actually implement the algorithm. So this is the view of what we implemented. So each gantry has different parameters we actually calculate, and we actually produce a simulation underneath it, and it's a more like real-time estimation going forward from the beginning of the day to the end of the day. And those not highlighted part is already happened. This highlighted part is estimated. So it keeps changing it. So we actually have a system in place. Any questions? Yes.
So when a patient comes in, it could happen that just one of the gantries is occupied and 3 of them are free.
It could.
It could. So in that case, do you have some forecast for 2 of the others, or you treat the 2, there's only one constraint?
We treat only one patient. And normally we don't have that happen because we always pre-schedule those patients. So we try to pack all 4 gantries from 7 o'clock. This facility are open actually from 7 a.m. to midnight. So that's how they operate.
And so a related question was, does scheduling the patients factor in the fact that you want to keep patients with similar treatment times at the same time?
No. We did a study, we're hoping that to do that, but unfortunately they feel like, then you make the patient who has a long treatment, has no option, has to come in the later of the day. Because you don't want them to pair up with those shorter patients so that to make them wait long. So they don't like the idea. Any other questions? So do I still have a time to go to the third one? The third one is called provider pairing. So the concept is this. This is a procedure. It's called TAVR procedure. I'm not going to try to pronounce what is TAVR. It's a transcatheter something. Okay, so this is TAVR. So one thing about industrial engineering, you don't have to know the terminology. You can still do the work. That's what I do. Okay. So the TAVR procedure is when your blood flow is clogged. is clogged. What do? You put some balloon inside. And the balloon is going to open up and close up, open up and close up to regulate your blood flow so that you don't have any heart conditions. So that's what this TAVR procedure do. The TAVR procedure involves two different providers. One is called interventionalist. The other one is called cardiac surgeon. The surgeon, purpose of the surgeon, intervention can do the procedure, they don't need surgeon, but the surgeon is the purpose surgeon being in for the consultation, also for the procedure itself, is to prevent for something accident happen. They have to do open heart surgery right there. So they are standby. So what this does is think about this. So when patient requests to perform this procedure, they need to see the interventionalist at the same time see the surgeon. And then both the same interventionalist and surgeon is going to do the procedure. So that's a different time. So the consultation could be today. The procedure could be a month from now. It depends on the availability of this pair of providers. You remember the pair provider, your time and my time, your calendar and my calendar is never the same. So how do we find the time? So even accidentally we find the time, your time and my time, oh, we are able to see the patient today. You see the patient. What's the likelihood of your time and my time pair up again in the near future? It's very difficult. So that's why this project started, because they have difficulty finding the right pair of provider. So the problem is the lead time, because remember the lead time is from the consultation to actual procedure itself. So you want the lead time to be less than 30 days. The problem is if you do right now the average lead time about 34 days, which is not good. The problem is after 30 days, the patient has to redo their HMP. HMP is a history and physical. The history and physical. So they have to redo the history and physical. And 64% of patients has to do that, which is not good. When you do HMP, it means the fellows or residents, they have to spend more time with these patients, and we can charge the patient more. So those are the problem they have. So the benefit we're trying to do, we try to pair them up so that lead times is minimum, and they don't have to do all those repeat work anymore. So that's the description of the project. So what we end up doing, this is the algorithm. It's similar to a greedy algorithm. So those are some of the parameters. We have the total non-interventionalists and the 4 different surgeons. So you know 9 times for the 36 different payers. So you would need to find 36 different payers. What's the availability from the consultation to the procedure itself. So those are some of the parameters. But I think I want to show you the algorithm. So I'm going to make it very simple. So on the top, 1-1 means intervention number 1 paired up with surgeon number 1. 1-2, intervention number 1 paired up with surgeon number 2. 1-3, etc. So those are the different pairs. What this algorithm does, we know their availability. We know their availability before they even schedule anybody. So the C means they are scheduled to see patients. P means they are scheduled to treat patients, to do the procedure on the patients. So what this does, we go through the search algorithm. So even day 1, when a patient comes in, there's 3 choices for patient. You can do a pair 1-1, you can do a pair 1-2, you can do a pair 1-4. There's 3 different choices for consultations. And if you look at P, 1-1, the P is going to be on the day 8. 1-2, the first P is going to be on the day 23. The 1-4, the first P is going to be day 5. So which one are you going to pick? You're going to pick the pair number 1-4. So that's the algorithm. So this algorithm can run it every time when a patient needs to be scheduled. We implement this. So this is a programming Visual Basic, and then the automatically pour the availability into the Visual Basic and then perform this algorithm. So when the one patient comes in, the scheduler just need to hit the button, tell me which pair I should pair the patient. I should pair with between the interventionalist and the surgeon, and then the algorithm is going to tell you when is a consultation, when is a procedure. So that's the algorithm. So can you run optimization for that? Yes, you can. But one thing about optimization is we often like to satisfy patients because we're in the business of treating patients. Patient is that's their pocket, right? So we pick their pocket. So the one thing is when patients want to schedule appointment, the last thing we want to tell them say, hey, I'm going to tell you next week because I'm going to collect enough patients. I'm going to run optimization algorithm because optimization algorithm you cannot run with one patient. One patient there's no optimization for it. You just do the search algorithm, right? In order for you to have an optimal solution on this one, you have to collect enough patients so that you can run optimization so it's more efficient that way. Because patient doesn't like that, unfortunately, we just create those algorithms for it. Because frankly, the first patient coming, do I have to schedule on day one? No, I could schedule on day two. Because optimization will tell me day two is the best options. So given I have 20 patients, I can fit into this one. But it doesn't have to be starting from day one. Right? That's what optimization could determine. But in order for us to use this greedy algorithm, we have to start from the very beginning. Because you check every single patient in sequence. Any questions? So there's a bunch of scenarios we run. So I'm gonna show you the result. The results is this one. So we look at the lead time. So we have a bunch of different ones. They no longer use this prior things, but that's not what they currently do. Let me show you what they currently do. What they're currently doing is when the patient needs to be scheduled, the scheduler is going to contact the scheduler from the surgery side. And they say, hey, I have a doctor so-and-so is available. Can you check the surgeon so-and-so? Can you check which surgeon can actually pay out with the doctor? So they can pick whatever the surgeon they can see. So they don't have any policy able to help them to make decisions. So that's what the current practice. So you have seen the proposed method. So this is a comparison. From the lead time standpoint, on average 22 days, and using the algorithm reduced to 9 days only. So that's a big saving. That's a big savings. And because we actually search every single day, so we are able to improve the number of pairs. Number of pairs. Improve number of pairs means what? We are able to see more patients. Because right now they don't have policy. So right now they are doing 54 patients, 54 pairs, but now we can increase to 58. So any questions? Yes.
From the patient side, all providers and all interventionalists, they're identical. So it's just about availability and there's no preference for a particular provider.
No preferences. I think if a patient needs put that things in the broad flow in their vessel, I think anybody can do it. So as long as we can find a provider helping that. Is there a case that patient particularly say, I want a particular provider? Yes. Because some provider is more senior, they are more well-known in the nations, and their referring provider say, you need to have this provider do your procedure. It could, but unfortunately, if that's the case, patient tend to wait longer to have procedure. Yes.
So if the patients have some patients have patients, then how long would you be able to wait to hold on before matching them? Because I believe instead of matching just in time, if you wait just a little bit, you may have a slightly thicker market for matching.
So for this entire algorithm to run, I think it's about 2-3 minutes. So when the patient come in, they run this algorithm, 3 minutes, they will have the solution for that data.
Oh,
very quick.
So how many patients do arrive in 6 minutes? What is the arrival rate?
There's not a lot of patients. It's not, look at that, we only have 58 pairs.
Yeah.
58 pairs in probably 6 months of time. So we only have 58 patients.
Why would you run the algorithm every 3 minutes? Then you would.
Because we just had when patient want to be scheduled, we want to give them the answer right away.
Oh, okay. I see. Then, yeah, so that's what I don't understand. What is the scheduling problem here? Because then.
Scheduling problem is right now they don't have this tool to help them find the payer. Because the interventionalist department is one department, surgeon is not a department. So when interventionalists getting the patient request, they pick up the phone, say, hey, I have a Dr. So-and-so here is available next Tuesday. Can you find somebody from the surgeon side they're able to do Tuesday? So they are negotiating. So they don't even look at say, okay, I can schedule for consultation. What is the likely procedure going to happen? So they don't have that, they don't have the algorithm in place. They can see it. If they spend time, they should be able to find this algorithm to do. But this algorithm basically help them to find a solution right away.
I see. So there is no cost of allocation, the shadow cost of the surgeon's time, or anything. You don't want surgeon occupancy levels.
No, I think the surgeon has to be there. Remember, surgeon is paid by salary.
Mhm.
So if they are there 6 hours, they got paid the same. 10 hours, they got paid the same. So there's no particular cost for it.
So a lot of times the surgeon is just sitting there.
Yeah.
Because there's not enough patients. Okay.
But keep in mind, surgeons sitting there, they have a monitor and they have to. But keep in mind, surgeons sitting there, they have a monitor and they have to be watching out for every single. They talk to the interventionalist. Don't touch that. Don't do that. So because they are preventing for any major issue could happen. And he's basically standby. So think about this. I understand. You feel like a surgeon just sit there. I feel the same way too, because I actually observe everything sits there. But the thing is, they have a probably like 3 or 4 procedure happen at the same time. And I cannot have one surgeon oversee 4 of them. What happened, 2 of them happen. You need surgeon, what are you gonna do? You need 2 surgeons. You cannot, so we rather play safe and so on. This is human life, so we are putting stuff into human body. So this is the tool looks like. So we have the availability we know, and we have the consultation schedule, and then we have procedural schedule, and then we end up creating an algorithm. This is basically the pseudocode of the algorithm behind it. You will run it, it will take up everything. So this is the output. So the output basically tell you the first pair available is interventionalist Dr. Huang and the surgeon Dr. Rose, and the clinical time is June the 2nd. Procedural time is June the 3rd, and then the other procedure June the 5th. The reason right now the algorithm is the same, but right now the 2 procedure is because the procedure actually taking longer. So one half day of the clinic, I can see 4 patients. Each procedure half day I can do 2 procedures. So one clinic pair up with 2 different days now. So the algorithm stay the same, the concept is the same, but now we're just doing 2 different days. Because after I come up with the first algorithm, they say, oh, the 4 patients in the half day, both interventionalist and surgery, they won't be able to do all the procedure in the whole day. So they only do procedure half days. So you have to separate into 2 different days. You used to be able to do procedure whole days. Yes.
So one thing I'm not able to understand here is like, why should this matching of the calendars of the surgeon and the interventionist happen when the patient is requesting? Because like there is no input from the patient coming in, right? Like for one thing that might be possible is like at the beginning of the day, you do some matches and you have already some set dates, and as the patient comes in, you just give the first available one.
Keep in mind, when this one here, we know what's the clinical day, what's the procedure day. So remember, they are not only, surgeon is not only seeing the TAVR patients, they see other patients too. So we wanted to run it at the time of patient request because they might filled out by somebody else, by someone else. Because remember, cardiology surgeon, they help with the procedure. They also help with the surgical patient as well. So there's a ton of other patients need their help. Interventionalists, yes, they are only doing this. They're only doing this particular procedure, but surgeons are not. But we only have a 4 surgeon, remember. So their time is very difficult to find. So we run it at the time, the request, so that we can have their time available for other things for them to do.
So, but then there might be a possibility of like having some kind of like a draft matches ready,
Yeah,
and
you could.
then
Yes,
when the request comes, you check if it's still available, and then if so, you.
they could. Does that serve the same purpose stuff? I think it serves the same purpose, but this way is more dynamic. So you don't have to run that and then start checking it, right? So how are you going to check it though? Is the system going to check for you? Or the scheduler has to open the calendar and start looking, oh, this pair has been scheduled, that pair has been scheduled. So I think one of the things we can like to do is we like to make a decision on the fly if it's possible. Especially in a real-time format. Any questions? So this is all the 3 case studies. Thank you.